Hello and welcome. Today, we're going to pull back the curtain on how doctors tackle one of the most complicated puzzles in all of medicine, cognitive impairment. We're going to explore the practical, step-by-step approach they use to turn that initial feeling of concern and confusion into a clear, actionable diagnosis. So let's start with the number, 131.5 million. By the year 2050, that's how many people around the world are projected to have dementia. It's an absolutely staggering figure, and it really highlights why this matters so much, not just on a global scale, but for every single one of us. Right, because behind that huge number are individual people, individual families. So when you or someone you love starts to notice a change, when that first seed of worry is planted, what happens next? How does the medical journey actually begin? Well, that's exactly what we're going to break down. Okay, so the first thing to know is that this whole process doesn't start by jumping to conclusions. You have to think of it like a detective arriving at a crime scene. They have to methodically gather all the initial clues just to see if there's even a case to pursue. And this flowchart shows us exactly where that detective work kicks off. And you know what? It's not with some high-tech brain scan. It starts with a conversation. If you look right at the top, it all begins with the patient's own complaint. But, and this is key, it has to be confirmed by what's called a reliable informant. That's usually a spouse or a close family member, someone who can give a really clear picture of what's actually changed over time. So after that initial talk, the clinician breaks out their toolkit. This includes things like bedside screening tests. Maybe you've heard of the MoCA test. But a huge part of this first stage is actually ruling things out. They have to be sure the symptoms aren't being caused by something else that can look a lot like dementia, like delirium or even severe depression. All right, so once it's confirmed that yes, there is some cognitive impairment, the next big question is about severity. And this leads us to a really crucial distinction, the difference between mild cognitive impairment, or MCI, and dementia. In both cases, there's a cognitive issue. The absolute key difference, the bright red line, is whether or not it messes with a person's ability to function independently. We're talking about things like managing their own finances, driving a car, or organizing their medications. That's the decider. So, with the impairment confirmed, the investigation gets deeper. The question is no longer, is there a problem? Now it's, okay, what exactly is the problem? It's time to build a detailed profile of the condition. And this chart shows that cognitive impairment isn't just one thing. It can hit different parts of the brain's function, which doctors call domains. As you can see here, they systematically check 6 of these key areas to create a kind of unique cognitive fingerprint for every single patient. And here are those 6 domains. You know, we all tend to think of memory first, and that's a big one. But it also includes attention, executive function, which is like your brain's CEO in charge of planning and problem solving, language skills, visual spatial abilities, and even behavior. Figuring out which of these are affected is absolutely crucial for what comes next. With that cognitive profile, that fingerprint in hand, the clinician can finally start following the leads. And as we're about to see, different primary symptoms will take the investigation down completely different roads. It's like a fork in the road. So, let's take the most common path first. What if the main problem, the thing that started this whole journey, is memory loss? This algorithm shows us the logic, and it is definitely not one size fits all. A clinician has to think about how long the symptoms have been going on and how old the patient is. So, for instance, a 70-year-old with slow, steady memory loss, that points one way, likely towards late-onset Alzheimer's. But memory loss that comes and goes or starts before age 65, that triggers a totally different line of question. But let's just pivot for a second. What if the first sign isn't about memory at all? What if it's a huge, out-of-the-blue change in someone's entire personality or behavior? Now look at how different this path is. If the main symptoms are suddenly a loss of empathy or they're acting really impulsively, the algorithm points towards something called behavioral variant frontotemporal dementia, or BVFTD. Or, if there are complex visual hallucinations, the investigation leans toward Lewy body dementia. You see? The very first clue completely changes the direction of the whole investigation. Of course, not every case is that straightforward. The clinical picture can get a lot more complicated, especially when motor symptoms show up, or when the cognitive decline is happening alarmingly fast. This flowchart really shows that complexity. When motor symptoms like Parkinsonism, that slowness, stiffness, and tremor are part of the picture, the diagnostic map just explodes with possibilities. The doctor then has to consider this whole range of atypical syndromes, like progressive supranuclear palsy or multiple system atrophy, and each one has its own unique set of clues. And then you have the most urgent scenario of all, rapidly progressive dementia, or RPD. This is when someone goes from being totally fine to meeting the criteria for dementia in less than 2 years, sometimes even just months. Its speed demands a completely different, much more aggressive diagnostic approach. Now, the list of things that can cause RPD is huge, so you can't just test for everything at once. It's not practical. Instead, clinicians use this really systematic, tiered approach, which you can see visualized here as a pyramid. This lets them be both thorough and efficient, starting with the basics before they move on to the really specialized stuff. So let's quickly break down that pyramid. Tier 1 is the core testing. This is the foundational stuff everyone gets, like blood work, a brain MRI, and a basic look at the spinal fluid. Tier 2 is expanded testing, and this is guided by those initial results. Maybe they're looking for specific biomarkers or infections. And then Tier 3, right at the top, is for the most complex, unsolved cases. That's where you get into advanced genetics and, if it's absolutely necessary, a brain biopsy. So after following all these different pathways and all these clues, the investigation finally reaches its goal, the verdict. And in cognitive neurology, the accuracy of that verdict is, well, it's everything. And this is why this whole systematic approach is so critical. Get this. A standard clinical diagnosis for Alzheimer's can have a specificity as low as 44%. That means more than half the people who get that diagnosis might actually have something else going on. The reason is that so many of these diseases can look alike at the beginning. This kind of rigorous step-by-step process forces the investigation to look beyond that first impression to find the real culprit. And the consequences of getting it wrong are so real. There's a quote from the authors of this approach that just says it all. An inaccurate diagnosis leads to the wrong counseling for the family, the wrong expectations, and the wrong treatment strategies. Getting it right fundamentally changes people's lives. You know, what we've just walked through is a lot more than just a series of flowcharts. It's really a map for navigating one of life's most frightening territories. It's a method for turning a scary mystery into a clear, logical process. And that leaves us with one final thought. By turning this diagnostic mystery into a clear path, how can we better support the millions upon millions of families who are on this journey right now?